Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Left Main Bifurcation Lesion Preparation before stenting with cutting balloon. This is my disclosure slide, and I'll go for next one. As you see here, there is a case example, female 75 years old with stable angina, class 3 and previous PCI for mid-LID with BMS. I will tell later on why there is a BMS, because actually this is a case which done more than 10 years ago. And why it is important, because actually around 20 years we do cases like this. And we have experience with several thousand left main cases with lesion preparation. Risk factors: hypertension, diabetes, dyslipidemia, and comorbidities: atrial fibrillation, left ventricle ejection fraction 60, and 6 syntax score 23. As you see, the syntax score is not so high, but it is the usual its usual story about isolated left main, because as you know, left main itself not actually giving us a very high syntax score. Nevertheless, it doesn't mean that left main intervention is always very easy and not request from us real skills and understanding what we are doing. As you see here, it seems very well how it looks like. It's quite long left main body, and then you see there is a lesion what we call 111. And for this reason, what we should do and what we recommended is also recommended now in EBC guidelines, and not only that, what we need to use imaging. If you look on imaging, then you see in different here you see very well LID and also circ. And as you see here, there's a real calcium which we need somehow to prepare for good stent expansion. Also quite interesting is that at that time we always look on bifurcations, and it's not except left main bifurcation that it's best way how to treat is to use one stent strategy. And of course, now we maybe know a bit more about that, how we use culotte stenting, or how we use crush stenting, or it's a new approach about double crush stenting. But as I said years ago, we really, and it's still important to understand that we prove the one stent strategy. But of course, again, in other cases we can't fix this if we use only one stent, and we need to prepare for also for second stent. But in this particular case, we really thought that maybe we will be happy with one stent. And as you see here, how it's done. First of all, it's wired both branch, left main and left main LID, left main circ. What we used transradial approach, 75 years old lady, radial approach, and 7 French guiding catheter. Sometimes people are saying that it is too big. In our practice, as I said, there's not one case, there's thousands of cases. Actually, usually radial arteries accepted this 7 French guiding catheter. And then we use cutting balloon 3.5, in this particular case 6 millimeters in both branches, in left main LID actually, and left main circ. After that, you see how it looks like. It's completely different, and this is important because you know there is a dominant circ. It really depends on anatomy how we can deal with fixing the lesion. There is a dominant circ, and as you see, there is now it's completely different flow, and also the lesion looks very nicely smooth. That means that actually we really prepared plaque already. But after the first stent implantation. As you see, drug-eluting stent 4.0, 20 millimeters, 13 atmospheres. As you see, after stent implantation, there is some pinching of sac. For this reason, we use kissing balloon, but after kissing balloon is still the residual stenosis, and then we use, which is not often used, the T-stent implantation, and we use the drug-eluting stent 3.5, 8 millimeters, and kissing, final kissing, and even in that time we use a pot, and this is after final kissing and pot procedure. As you see here, there is seams how it looks like in spider view, and now it's a both branches flow is not flow is really good. It's TME3, and also if you look here, also angiographically, it looks nicely. And this is a post-intervention IVUS. As you see in post-intervention IVUS, there is a very good apposition, stent apposition. The symmetry index is okay, and stent implanted in good manner. And now I want to show you how it looks like after 10 years. And this is from our practice what we see, that if you do good stent lesion preparation, if you do good stent expansion with proper post-treatment and imaging, the results are really good. And as my favorite, I mean, picture, it's Leonardo Gioconda, then you see that it's really important to be focused on details, but we still need to look on pictures. And thank you very much for your attention.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Orbital Atherectomy for Treatment of Severely Calcified Coronary Artery Bifurcation Lesions. Management of bifurcation lesion presents a challenge to interventional cardiologists and are associated with high rate of procedural complication and long-term MACE. Optimal plaque modification is most important step prior to stent deployment in calcific lesion. Safety of coronary orbital atherectomy has been supported from previous Orbital trial that led to FDA approval. Low risk of MACE with the OA of use of OA in bifurcation lesion has been shown by us as a single center study. So this is a case of a 51-year-old male who presented to an outside hospital with non-STEMI 2 days prior. They had a cath there, had significant LAD disease and a known old total circumflex disease. He was transferred here for high-risk PCI. Known hyperlipidemia, smoking, controlled hypertension, had no prior known cardiac history otherwise. On medication of Lipitor, low pressure aspirin. So cath had shown significant LAD diagonal lesion and a total occlusion of OM1 with a syntax score of 22, EF 55. So the plan was to do an OCT-guided PCI of calcific LAD diagonal lesion using orbital atherectomy. So this is the angiogram, mid-LAD, significant lesion involving a moderate size diagonal, which also has some significant disease. We saw it in two views. So this is orbital atherectomy, OA, before where we see that there is calcium arc of 180 degree with the maximum thickness of 0.7 millimeter of the calcium. So we did orbital atherectomy, 80,000 RPM for 60 seconds or so with a wiper wire. So as soon as we did orbital atherectomy, you see there definitely is a slow flow in the main vessel. So to rule out the dissection or so, immediately go with the balloon and then give a lot of vasodilators. Subsequently, we wired the side branch with a fielder wire, and we had a run through in the main vessel. So we had to remove the wiper wire of the orbital atherectomy. Despite that, you still, the flow got better, but you see some dissection now in the LAD. So with the 2.2 balloon, we dilated the side branch, and then also we dilated the main branch. Since the side branch had disease and moderate size, we decided to go with a dedicated two-stent technique. We use a mini crush stenting technique where Zions 3538 was used in the main vessel, and Zions 2.15 millimeter was used in the side branch. Final kissing balloon, And this is the final angiogram, which shows excellent result with a good flow. This is the final OCT, which shows no edge dissection, as well as a good malopposition of the stent in the main vessel. So just to show you orbital atherectomy, rotational atherectomy, everybody knows what how these devices work. One has eccentrically mounted diamond chip, and rotational atherectomy has it at the tip. So we were the first one actually to use orbital atherectomy in calcific bifurcation lesion in a small group, and we showed that it is feasible. We were the part of a large multi-center registry for orbital atherectomy for treatment of severely calcified coronary artery bifurcation lesion. It was a multi-center analysis that got published. So if you see here, OA both in bifurcation and non-bifurcation, that in bifurcation lesion, the dissection is slightly higher. Perforation embolization was comparable to non-bifurcation lesion. So when you go to propensity scored match, what we saw that 30-day outcome was equivalent in both bifurcation as well as non-bifurcation lesion, with statistically no difference between the two. So this registry actually included larger and more complex patient population compared to the original Orbit study, but 30-day MACE was comparable to the Orbit study. We were the first one also to show the mechanism of action of orbital atherectomy. So what we, when we did imaging, what we saw was a calcium arc was the key factor. That if the calcium arc was bigger or a larger arc, then your type of dissection, which is type A, type 2, dissection or cuts were smaller. When you had a smaller arc, then you got a deep intimal dissection, which we called it as type 3. This is the deep cuts that you see here with the OCT, calcium sanding when you do OA, and as well as the calcium cracks that you see when you do OA. So just to see how can we take care of this calcific bifurcation lesion, always we decide whether it is left main or non-left main, and decision of calcium can be made based on angiography or imaging. So if in the main vessel, which of the left main, that if you have moderate calcium, consider just cutting balloon, severe calcium, you can decide any kind of atherectomy that you want to do. If the side branch, which is usually the large vessel circumflex or LAD, has moderate, you can do cutting balloon and decide on and has significant lesion, do 2-stent technique. But if the side branch has severe calcium, you may have to do atherectomy, even atherectomy also of the side branch, and then do 2-stent technique. So for the non-left main, if you see, for the main vessel, same. If you have moderate calcium, cutting balloon. Severe calcium, do OA, IVL, or RA. If the side branch is large and you have a more than 70% diameter stenosis and the lesion is longer, also you can consider a rotational atherectomy, OA, IVL, and then do 2-stent technique. So how to take care of calcific lesion? We actually have an calcific app that is free to be downloaded. We tell you the various techniques, how to do orbital atherectomy, both for bifurcation, non-bifurcation lesion. Various apps are available on cardiologyapps.com. This was a Bifurcate 3D app where we are showing animation how to do a bifurcation technique of whatever kind of technique that you want to learn. Here we are showing a mini crush technique. So just for ladies and gentlemen, to conclude, the goal of bifurcation PCI is to achieve optimal result in main vessel and maintain physiology patency of the side branch. Provisional side branch stenting should be the default technique, that provisional stenting should be done. 2-stent technique might be preferable for a large side branch with greater than 70% diameter stenosis, or you have a long lesion greater than 10 millimeter. Imaging to predict any complication should be considered. So if you have severe calcium, optimal preparation of the main vessel and or side branch using various devices, whether it is orbital atherectomy, RA or IVL, is safe and efficacious in treatment of bifurcation lesion. And thank you for your attention. These are the various apps that are available on cardiologyapps.com. These apps can be downloaded free and for interventional cardiologists. Thank you.
Dear Chairman, thank you for the invitation to present at the EBC 2021. The title of my presentation is Principle of IVL, Current IVL Data and Indications in Calcified Coronary Lesions. Regarding the stent-oriented goals after PCI, the efficient stent delivery is essential. Thus, we have learned also from intravascular imaging that a good mechanical results can be achieved when MSA is greater than 80 or 90% with an absolute MSA greater than 5.5 square millimeter. If dissection is not present, plaque burden at the edge and malposition should also be avoided. Well, from several studies, we know that an adequate stent implantation can reduce clinical events and, of course, symptoms on the one hand side, but also often results during lesion preparation, which is mandatory to achieve such a good results in procedural complication. So balloons have an insufficient force to crack calcium, often results in barotrauma or balloon rupture. Also, atheroablative strategy are also limited by a wire bias, only potentially resulting in slow flow situation or even perforation. Taking this into account, intravascular lithotripsy has been introduced, especially in lesions where calcium angle is more than 180 degrees and calcium thickness is more than 0.5 millimeter. Additional consideration using IVL are vessel with an lesion and a large residual lumen more than 2 millimeters, or ortho-osteal lesions, or of course bifurcations. The intravascular lithotripsy comes with a balloon catheter and a generator. The generator produces energy which are applied by the emitters in the balloon catheter. A small electrical discharge at the emitters vaporizes the fluid within the balloon to create rapidly expanding bubbles that generates the sonic pressure waves and then collapses within a few microseconds. When wave impact the calcium at nearly 50 atmosphere, they create a series of microfractures and then makes the vessel more compliant. Here you can see the effect of lithotripsy either in OCT, here you can see the microfractures, or in IVUS. In the latest data coming from the CAD III trial, IVL showed a high safety endpoint. The primary endpoint, which was freedom from MATE within 30 days, was observed in 92.2%. The lower confidence boundary of 89.9% meets the performance goal. Here you can see the clinical endpoints, which were rather low. However, there was a high success rate after treatment with IVL. Finally, I want to show a clinical case which shows a severe calcified lesion, which is nicely demonstrated in the intravascular imaging, which was OCT in the right coronary artery. And IVL treatment was then applied here in the severe calcified lesion, which results in a high compliance of the former stenosed vessel. So the IVL treatment leads to better vessel compliance after creating the microfractures, resulting in inadequate stent expansion. So therefore, I like to conclude Adequate stent deployment following after optimal lesion preparation is mandatory for better clinical outcomes. Conventional strategies in severe coronary calcification might be insufficient, and therefore intravascular lithotripsy offers an alternative treatment to ensure optimal stent deployment, thereby demonstrating efficacy and safety. Thank you very much.
Dear Chairman, thank you for the invitation to participate in the European Bifurcation Club 2021. I'm Alfonso Jurado Roman from La Paz University Hospital of Madrid. And the title of my presentation is Bifurcation Lesion Preparation with Rotashock in Bifurcation Lesions. I have taken the liberty to change a little bit the title, as we prefer the term rotatripsy, as it was the term we used when we firstly described this technique. The clinical case is about a 74-year-old female with several comorbidities, diabetes, hypertension, lupus, previous renal transplantation, who was admitted in our hospital for a non-STEMI episode. The left ventricular ejection fraction was 40%, and she suffered from peripheral artery disease, very severe artery disease with impossibility for radial or ulnar approach, and also with severe femoral disease. This is the first angiography with a calcified nodal distal left main and a critical lesion at proximal mid LAD that produced a TIMI2 flow. The patient was stable at this point. So in summary, we had two bifurcations in series, one at the distal left main with a calcium nodule, 100 of Medina, and the other one at the proximal mid LAD with some affection of the diagonal branch, 111 of Medina, but the diagonal branch had 1.52 millimeters of diameter. So we decided to perform the PCI without any left ventricle support because of the peripheral artery disease, with femoral approach, EBU 4-7 French. And we could cross with some difficulties to LAD with a cyan black wire over a fine cross microcatheter. However, the fine cross could not follow the wire, and we couldn't use it to exchange this wire and change for the rota wire. So we predilate with small balloons, and this is the angio after predilatation. We improved a little bit the flow, and we could observe better the calcium nodule at the distal left main protruding at this point, without significant impairment of the ostium of the left circumflex. So we follow with the initial strategy, the rotatripsy, advancing the rota wire through the fine cross and performing a rotational atherectomy with a 1.5 bar. We knew that rotational atherectomy wouldn't be enough to ablate this calcium nodule, but it was necessary to deliver the shockwave balloon. So after rotational atherectomy, we used a 3.5 shockwave balloon, and we applied 80 pulses at distal left main and proximal LAD. Before these pulses, before lithotripsy, we protected the side branch, the circumflex, with another wire. That, as you know, is one of the advantages of the lithotripsy against rotational or orbital atherectomy. This is the IBUS after rotatripsy with some intimal ablations and deep fractures produced by rotablation and shockwave. And after that, we decided to post-dilate with a 3.5 NC balloon at high atmospheres. After that, we implanted two overlapped drug-eluting stents at distal, at left main and proximal LAD. And after that, we performed POT, an aggressive POT with a 4.5 millimeters balloon according to the measurements in the IVUS. This is the final result in the angiogram. And this is the measurement in the IVUS with a 10 millimeter square area, minimal luminal area at the calcium level. So in summary, we think that rotatripsy, the combination of rotational atherectomy and intravascular lithotripsy is a great technique when you have severe lesions and deep calcium, because rotational atherectomy is needed to create a tunnel after intimal ablation to deliver a shockwave balloon that cannot cross if the stenosis is very tight. And we know that rotational atherectomy cannot ablate deep calcium that also only performs intimal ablation, and shockwave does it. So this is how we reflect this combination of effects with intimal ablation of rotational atherectomy, as you can see here, and deep fractures of shockwave. So this is, we have published the first series of this technique, and probably the take-home message is that when you have critical stenosis with deep calcium, probably this is the best choice for prepare the plaques. In addition, when we are facing a bifurcation, lithotripsy permits to protect side branches, especially when we are talking about the left main. So that's all. Thank you for your attention.
Dear Chairman, thank you very much for the kind invitation. The title of my presentation is the usefulness of OCT-guided debarking in bifurcation. This is my disclosure. I would like to show 4 cases of debarking at bifurcation. The first case is calcium exists at opposite side of carina. The case is 71-year-old male, effort angina. You can see the severe stenosis in LAD and involving a diagonal branch in here. OCT shows at the opposite side of a diagonal branch, you can see the calcium in here. We have done a load ablation using a 2.0 millimeter bar like this. And then Zions stent 3.5, 23 implanted to the LAD and finished with KVT using a 3.5 and 2 millimeter balloon like this. Final angiogram showed a beautiful result. OCT show that this calcium is ablated by load ablation in here. After stenting, no carina shift happened and wide open of the stent. 1 year follow-up showed no restenosis. If there is a calcified plaque in the opposite side of carina, carina shift may happen after stenting. Load ablation recommended before stenting. The second case is calcium occupies the orifice of side branch. This case is 70-year-old male, effort angina. You can see the calcium both sides of LAD and diagonal orifice. Load ablation was done in the 1.75 bar in the LAD, and then also load ablation to the diagonal branch orifice like this. OFDI show at the orifice of diagonal branch still occupies the calcium in here, but the lumen gain looks okay. So we implanted the result stent 2.75 30 into the LAD and finished with KVT. 1.5 years follow-up show no stenosis. If there is calcified plaque in side branch orifice, load ablation may help to result in single stenting without compromising side branch flow. The third case is eccentric calcium with severe tortuous bifurcation. This figure shows the left main trunk bifurcation with eccentric calcium severe tortuous LCX orifice. In this situation, load ablation with push force has a high risk for perforation. Orbital atherectomy, diamond back, with pulling back has a less possibility of perforation. This case is 77-year-old male. You can see the calcium both LAD and circumflex is very tortuous lesion. Also, this LMT severe stenosis was observed in here. And at the orifice of circumflex, Also, there is a severe stenosis. Using a glide assist, OA caster deeply into LCX and start pulling back ablation until LCX orifice. And then node ablation was done at the orifice of circumflex using a 2.25 millimeter bar. After circumflex balloon inflation, you can see the expansion in the circumflex orifice. And OADS show this is after orbital atherectomy low speed, ablation effect was observed in here, and high speed further ablation effect, and then node ablation 2.25 ablation effect was seen in here. And the ballooning make a crack in there and wide open of circumflex orifice. For the left main tract LAD, this is a straight form of the vessel, so we have done the load ablation primary to the LMT to the LAD, and Zion Sky Point 4.018 was implanted from LMT to the LAD, and we cross the guide wire to the circumflex, and the recrossing point looks okay. This is the stent link is here, and this is a LMT distal stenosis lesion. Load ablation effect was seen in here, and cutting make a crack in here, post stenting, and post cavity. You can see the wide open of a circumflex orifice. And 3D OFDI show wide open of a circumflex orifice. Final angiogram show good result. Circumflex orifice looks okay. For eccentric tortuous calcified lesion, pullback orbital atherectomy, diamond back may be effective to make an incision in calcified lesion. Aggressive following load ablation may lead to optimal lumen gain. The final case is abundant soft plaque occupied side branch orifice. 53-year-old male, at the orifice of LAD, severe stenosis, you can see. And at the orifice of LAD, diagonal branch and the high lateral branch and circumflex branch involved in the bifurcation. To avoid the LMT stenting, we have done a directional atherectomy using flex cut at the orifice of LAD, and the ablation effect looks okay. Then we implanted Ultimastar 418 at the orifice of LAD to the distal LAD. Final angiogram show beautiful result. And the follow-up angiogram show no stenosis. If there is soft plaque in osteo-LAD, directional atherectomy may prevent plaque shift into LMT and avoid LMT bifurcation stenting. Thank you for your attention.